series that is dealing with different aspects of the management of patients with red blood cell disorders. And this first one is managed by Professor Holger Cario. I'm very glad to introduce him. He's a very active member of Working Group 2 and also an expert physician working in the Department of Pediatrics and Adolescent Medicine at Ulm University Medical Center in Germany. And he's an expert in red blood cell disorders and bone marrow failure disorders. Because of this, he has many years of experience in managing patients with iron overload. So this is the topic of today. I would kindly ask you to maintain your microphones on mute during the presentation. At the end, we will take all your questions. And if you could raise your hand through Teams so we can maintain some order at the end, that would be great. So without further ado, please, we can start the webinar from today. Thank you very much.
Hello, welcome everybody. I'm very glad to meet you today to talk to you about iron overload. So Tirola will be so kind and share the slides. Because of some connection problems, I will be unable to share my screen today. So please.
Can you see my screen? I just shared it.
Yes. This is on the first slide yet?
Oh, I can't see it myself at the moment.
Perhaps it's still loading for some people. Maybe we have some internet issues. Perhaps, Holger, you can also open it in your screen and I will follow your guidance to change the slides for everyone.
So I even don't have my presentation open, but I don't understand why I don't see the presentation mode, because I can see everybody of you.
Can everybody else see the screen?
I can see it. I have the first slide. If you try to change from first to second, so Tirula, to see, because that didn't work before, to see now, yes, it works perfectly
Maybe
for us.
Holger,
Do you have double screen, Holger?
Oh, I think it comes now. I think, oh, the second. I think you see the second slide. It's right. Now the first one.
Now it's
yes, good, good. Okay.
Oh yeah, very. I think in the middle of the day it's the worst time, because everybody's working on the nets. Okay, so we start, and the second slide is the one with my potential disclosures of activities where I'm engaged with pharmaceutical companies, as many of you. And we come to the next slide. So if we talk about iron overload, complications and management, then we always start with some overview on the background of iron homeostasis in the human body. And as most of you will know, we have about 4 grams of iron within the body, and the vast majority of it is incorporated into red cells or in its precursors in the bone marrow. And there's another part, 1/4 of body iron, which is stored in the liver. And then we have some tissue iron, for instance, in the muscles, like myoglobin, and then in many other organs as a smaller amount of iron. And as you know, we only take up iron from the food in an amount of about 2 milligrams per day, a very, very small mass of iron, and it's also the same amount of iron that we excrete, and we do not excrete it actively, but we lose iron by losing skin and some other tissues regularly, physiologically. And with this important need of recycling of the stored iron, it's of course very important that we have a very well functioning regulatory circle. And it's the next slide, please. And this is done by the peptide hormone hepcidin, which is produced by liver cells and responding to iron to the iron amount of iron in the body, in the blood, and which is then censored by liver cells. And hepcidin is increased in the presence of high iron values, and is increased in response to inflammatory cytokines. And high hepcidin leads to a reduced resorption of iron in the intestinal cells, but also to a reduced release of iron from the macrophages. On the other hand, hepcidin synthesis is suppressed by erythropoiesis, and one factor which is signaling this way is ERFI. So that if we have a very high need for iron, then hepcidin is low and iron can be resorbed and can be released by macrophages and vice versa. The next slide, please. So if in this regulated circle something goes wrong, then we can have iron overload. And of course, it's the easiest way to produce iron overload is transfusion. If you have in mind that 1 unit of red blood cell, concentrated red blood cells with a hematocrit of about 60% stores 200 milligrams of iron, that's the 100-fold of the daily intake that we take enteroenterally, then you can easily imagine that many transfusions will very soon lead to an iron overload. What we don't have iron overload only in the case of transfusion. We can have it, of course, because of an increased resorption, as it is very well known, for instance, in primary hemochromatosis and rather frequent inborn disease. And then in all so-called iron-loading anemias, where an increased and sometimes even ineffective erythropoiesis will lead to ERFI production, hepcidin suppression, and therefore a high amount of iron resorption. And then another very smaller group leading to iron overload is the group of reduced iron utilization, like for instance in sideroblastic anemias. Next slide, please. This just shows again the mechanism of increased iron resorption. The next, please. Yes, so then I already told you that the majority of iron that is in the body is stored very safely. It is stored in the form of ferritin, hemosiderin, etc. But in the case of severe iron overload, and if transferrin is also overloaded, then we will have non-transferrin bound iron, and this is actually the dangerous form of iron, either in the form of the labile plasma iron or intracellularly with a labile iron pool there. And this free iron then will lead to the production of hydroxyradicals, so to redox active reactive stress within the cells, leading to membrane damage, disturbances of the respiratory chain, disorders of ion flux, direct DNA damage, and other things. And one important thing is the formation of extracellular matrix leading to fibrosis in different organs. So that's something we have to avoid, and or to diagnose if such complications already occur. So what does this make clinically? The next slide, please. Damage in the different organs leads to the corresponding organ disorder, and so the iron overload disorder, which was for decades the leading cause of death in patients with secondary iron overload, was hemosiderosis of heart, so cardiac hemosiderosis, which leads to cardiomyopathy, including cardiac failure, but also severe arrhythmia. Also, the liver is affected by iron damage, not only by leading to fibrosis and later cirrhosis, but also, and it's something we experienced in the last 10 to 15 years, more and more, to hepatocellular carcinoma, either in combination or even without additional previous hepatitis C infection. And the third large group of iron overload disorders is concerning endocrine organs. There we have a very, very iron-sensitive pituitary with damage causing growth retardation, hypogonadism. Hypogonadism, the most frequent endocrine disorder affecting about 2/3 of the patients, the adult patients. But one of the most, I think, important disorders in the endocrine sector is diabetes mellitus. And this is a combination actually of pancreatic insufficiency in combination with insulin resistance of the liver and other organs. And as everybody of you know, diabetes mellitus itself is a very severe and important disorder, difficult to manage over decades. And this to have, in addition to something, usually regular transfusion and iron overload of other organs and need for regular chelation with good compliance, etc. That's really, really a big burden. Then we have also thyroid and parathyroid glands insufficiency, which is more easily to replace than the other problems I told you before. So, next slide, please. So, as you know, we have some tools to work against iron overload, and we will come to this later. But even with the possibilities that we have over the last decades, we still see a lot of those problems in our population. Although those data here of the French thalassemia registry are meanwhile also 15 years old, it's the same situation today. So that we have in the elderly population, we have a higher proportion of patients presenting with such iron overload disorders, and still, as I said, with a high proportion, particularly of hypogonadism, even of secondary hypogonadism, secondary amenorrhea, and a very much shortened reproductive window in women affected by thalassemia and therefore by iron overload. The next slide, please. So how to manage iron overload? We have to look at the two major parts of this management. The first one is iron monitoring. So we are interested in the overall total body iron to know where we are and how much we have to do. But of course, we are also interested in a more specific iron overload of different organs. And as you will see later, this is not always the same that we find in the liver, which is primarily the organ we are examining for getting information on the total body iron overload. So we can access cardiac iron also by MRI very elegantly. And for the endocrine glands, although there are some MRI methods existing, it's still primarily a laboratory analysis which are used to assess these questions. And the second important part of iron overload management is the treatment, of course, and just as the example, because it's the most relevant for those patients which are regularly transfused, is the treatment of iron overload by using chelators and by producing stable chelates, which then can be excreted either by the kidneys or by the intestine. Of course, if we perform such a medical treatment using drugs, we always have to keep in mind that we have to have a balance of efficacy and toxicity for those drugs. This is something I will come to later as well. Next slide, please. Okay, what can we do to monitor iron overload? So as all of you know, we are looking regularly for serum ferritin, and serum ferritin has the vast advantage that it is non-invasive and not expensive, almost everywhere available, and it's correlating with hepatic iron, as you can see on the graph on the left-hand side. But how you also see, there is a huge scattering, particularly in high hepatic iron, liver iron levels, which shows that ferritin is not so reliable, particularly if you use a single measurement. In addition, serum ferritin is influenced particularly by inflammation, but also by liver disease, since it's acute phase protein. Therefore, if you will use it, and we use it, all of us use it, you have to do this by serial measurement. In addition, it's important to know that in different underlying disease, you will have a different correlation between liver iron and ferritin, as here in the example of thalassemia major or transfusion-dependent thalassemia, and on the other hand, on in thalassemia intermedia or non-transfusion dependent thalassemia. And in the table below, you can see it very exactly that at the same liver iron of, for instance, 15 milligrams per gram dry weight, you will have a very different ferritin levels corresponding with these liver iron levels. So we do need more than serum ferritin, and that's on the next slide, please. I think all of us use liver iron content. Why? So it's proportional to the total body iron content. This was very elegantly shown 25 years ago, meanwhile, in patients transplanted for thalassemia, which had an assessment of liver iron concentration before and after regular phlebotomy. And it's in the same time, the amount of blood removed and the hematocrit of the blood was monitored exactly. And from the iron which was within this blood, it was the amount of iron which was calculated then, it could be really elegantly shown how the correlation of liver iron with the total body iron actually is. We also know from even earlier studies that the liver iron content is very proportional to the quality of iron chelation, which is reflected by the iron chelator ratio. And so if you separate the groups in those who have a good iron chelator ratio and corresponding liver iron, then it discriminates very well in two groups with either in the lower panel, the upper line, a very good prognosis, but on the other hand, with a very low prognosis in those who have not enough chelation in relation to their body iron. Next slide, please. If we want to look for liver iron, so for many years, liver iron biopsies were the only tool, but nowadays, the method of choice is liver MRI. It's non-invasive. In comparison to liver biopsy, you have a big sample size that you can examine, and it's rather widely available, at least in high and most middle-income countries. We have different methods of liver iron measurement by MRI, and we have different modes of their calibration. So different types of liver biopsy were used for this calibration. This actually leads to the point that with different methods, you will have slightly different absolute values of liver iron. This should have to be kept in mind if comparing different methods or results from different methods. And the most important consequence, after my opinion, is that in one individual patient, you should always use the same method for follow-up of liver iron. Next, please. So it was shown when this method was developed that cardiac iron does not essentially correspond to the amount of liver iron. And this was shown on the MRI pictures in the upper left panel there, where you see in the upper panel a rather bright myocardium, but a very dark liver tissue. Dark liver tissue reflects high iron in the liver. The brighter picture, less iron in the myocardium. But in the lower panel, you have exactly the opposite. You have a very high myocardium, a very dark myocardium, highly iron loaded, but a much brighter liver signal. So we see that in those cases, there are cases with a huge discrepancy between cardiac and liver iron. Therefore, the specific assessment of cardiac iron is necessary. And this is done by measuring the T2 star relaxation time in the MRI. And it's important to know that the lower the time, the more iron is in the heart. And we want to have T2 star relaxation times which are longer than 20 milliseconds. It was shown very nicely that the T2 star value corresponds very well to the prognosis of a patient in the following 12 months. So in the right upper panel, you can see that with a decreased relaxation time below 10 milliseconds and even lower, the risk of suffering from cardiac failure within the next 12 months after such an examination is increasing dramatically. And in the lower right panel, you can see the same for the risk of arrhythmias in certain patients. So that means that if you have a patient with a T2 star relaxation time of less than 10 milliseconds, then you are urgently needed to do something against or to try to remove iron from the heart. The next slide, please. So as I already said, we are not able, at least not in a broad meaning and in many centers, to use MRI for the monitoring of endocrine organs like the pituitary gland or pancreas. So most centers will focus on laboratory examinations, which have to be performed regularly, particularly in patients older than 10, so starting with puberty and so on. And there's a variety of endocrine parameters, which is shown there in this table and which can be found in various guidelines. So one important point of my opinion is really the regular performance of an oral glucose tolerance test, because it allows you an early detection of impaired glucose tolerance, in the case also already of insulin resistance. And if you then can react adequately, you may reverse such problems in the patients. Next slide, please. Okay, so we come to iron elimination. So this is not a method for a regularly transfused patient, of course, but there are not only the patients with hereditary hemochromatosis, but also some patients with mild to moderate iron-loading anemias like congenital erythropoietic anemia or cellular disease, who can really benefit. And in addition, I forgot, in addition, patients after stem cell transplant, of course, who can benefit from regular phlebotomy. And this is one more time the graph which I already showed you some slides before with this correlation of total body iron and liver iron. As you can see in the table there in this study, which was the basis for this calculation, that with regular phlebotomy in the interval, like it is shown in the line above, it was the group was able to reduce serum ferritin significantly from 1500 to 110 milligrams per liter, and the hepatic iron from 11 to 1 milligram per gram drive. So it's a very efficient therapy, but if there is severe iron load, it's of course taking time until you are there where you want to be. Next slide, please. So for transfusion-dependent anemia, chelation therapy, as I said before, is the method of choice. When do we start with such therapy? Usually it's generally accepted a way to start if you have serum ferritin levels above 100,000 milligrams per liter, micrograms per liter or nanograms per ml, if you exclude inflammation as an underlying cause. At the same time, liver iron will reach the appropriate threshold, which is mostly mentioned as being higher than 3.2, but in some methods we use 4.5. This is something we use in most German centers as the value, since we use FerriScan as the liver iron measurement method. And usually these values are reached when you have 10 or until 15 transfusions in a young child. So usually in congenital anemias, we start at the age of 2, sometimes some months before already, but usually around 2, or at the latest in those who start early of about 4 years. And it's of course in lifelong treatment, which is necessary in those patients who are not undergoing later some curative approach to cure the disease. Next slide, please. So what is the aim of chelation? This was just a bit too fast, but not a problem. focus on the right side of the panel. So until, as long as we had only one chelator, and this was until about 2000 or so. So we had one chelator which had a high potential of making side effects, ophthalmologic side effects, hearing loss, bone cartilage disorders. We will come to this a bit later again. Then we used a so-called optimal iron chelation level, and this corresponded to the level of iron in a heterozygous hemochromatosis patient. It was between 3.2 and 7 milligrams per gram using the iron determination method. However, one has to keep in mind that those heterozygous hemochromatosis patients will reach those levels in the 40s or 50s of their life, but not as a young child. And therefore, it's not surprising that in regularly transfused patients who start early in infancy or childhood, we can see problems related to iron overload, even when liver iron was within these so-called optimal iron chelation level. Therefore, when we had additional possibilities of chelation, like we see next chelators, we had changed our goal. So now it's according to our guidance, we say, okay, deferoxamine was the first one. Liver iron should be hold at above about the threshold that's indicating chelation therapy. For the others, it should be aimed to reduce liver iron below the threshold levels, and in the cardiac MRI to have T2 star relaxation times higher than 20 milliseconds. And then we have only to keep attention that if serum ferritin falls below 500 or liver iron below 3, then one has essentially to adjust the therapy, and it's good to have somebody who's experienced with it. Next, please. So these are the three chelators that we have, and you know this. They differ with regard to the size of the molecule, to the mode of application, to the elimination half-time, and it's very important thing. And we have deferoxamine as only parenterally one and is only working as long as you continue infusion. Then we have deferriprone orally available, but you have to give it 3 times a day, and deferrazirox, which can be applied only once a day because it's rather long half-life. Another point which is I want to point you to is the dose of those chelators. As you can see, there for deferoxamine, we have with the lowest dose to the highest doses written there, it's a double of the initial doses, and for deferrazirox, it's even the 4-fold. But for deferriprone, we have a much smaller window, and that's something I think it's important in the clinical use. Next slide, please. In principle, all the key chelators work. They are working in reducing liver iron, and they are effective in a different way with regard to the heart iron. For the cardiac iron, deferriprone, the smallest of those molecules, is best able to enter myocytes and to bind iron there and to export it from the myocyte. And this explains why it is so effective in reducing cardiac iron load. This is a much lower extent that deferrazirox is be able to do so, and deferoxamine only indirectly can eliminate cardiac iron. For very high liver iron and very high total body iron, deferriprone might be inadequate because you have this small window, therapeutic window of the drug. So that's at least my experience, that in very high liver iron, this is not my first choice of drugs. Next slide, please. We have to consider that, as I said initially, that all those drugs also have a potential side effects, and I'm sure that most of you will know the most important side effects of those drugs. We have with deferoxamine to be very cautious in very young children because of the bone and cartilage damage. It leads actually to a disproportionate growth retardation that you can see if you meet elderly regularly transfused thalassemia patients who had only the opportunity to be treated with deferoxamine, who have this problem. And of course, the hearing loss and the ophthalmologic complications depend on the iron chelator ratio, and this must be monitored very carefully. For deferripiron, the most dangerous side effect is, as you know, neutropenia. But if you have mild neutropenia with neutrophils higher than 500 per microliter, and you will stop it, and it will come in normal values again, there are experiences that re-challenge, or in some cases, even with a very mild neutropenia continuation, is worth considering and not associated with rebound and with development of a new episode again. With those having very low neutrophils below 500 per microliter, they have to stop and shouldn't be re-challenged. And for deferoxamine, it's important, and an important observation, you always have to look and to adapt the dose to the degree of iron load and to the degree of creatinine clearance. Because in reduced creatinine clearance will change the kinetics of deferoxamine, lead to increased availability within the blood, and this may even worsen pre-existing problems, which in majority we see with renal impairment. It also includes the renal Fanconi syndrome, particularly in young patients which who are or have been overchelated. But it's also a problem in adults and may even show, together with other problems, causing hypercalciuria, which has to be monitored and managed. Next slide, please. So this is a summary of those parameters that we have to examine either on a monthly basis for some of the parameters, like the kidney parameters, the liver parameters, and then in addition some of the examinations which are done on a yearly basis. And on the left-hand side in the upper panel, there you see the regularly performed blood counts to exclude or to detect neutropenia. Next slide, please. So what can we do to avoid at least some of immediate side effects? This is one example for the deferoxamine, where arthralgias, liver enzyme increase, gastrointestinal problems were present, and were resolved by dividing the dose into 2 daily doses. And then in those cases, one can see in many of them that efficacy of the treatment can be even higher than in the single dose approach, and is something very easily done. Next slide, please. So this is one of my favorite slides, and one of the oldest, I think the oldest one almost included here, but it very elegantly shows the importance of compliance with chelation for the outcome. And this is here was the classic example of deferoxamine therapy, which shows that depending on the number of infusions, which of course is related to the compliance of a patient, you will have either a very bad or a very good outcome. And so this is important to deal with the drugs, to deal with the side effects, and to give as much comfort in this to the patient. Next slide, please. But as I said, there are patients who cannot be compliant, who have problems with the chelators, who have high iron overload, and we need intensified chelation. And these are the indications for intensified chelation. So severe cardiac iron overload, as I said, with a T2 star less than 10, or new symptoms in the sense of arrhythmias or heart failure. And there are some relative indications, so very high liver iron, impaired glucose tolerance, or newly detected diabetes, but also pre-treatment of stem cell transplant for those who are severely iron overloaded. Next, please. And what we can do is a lot. So we have, and this was the first method used, continuous 24-hour chelation parenterally, either intravenous or subcutaneous deferoxamine therapy, which showed either in a normal or in a little bit higher doses, a really good improvement of cardiac function related to this treatment, and very and this was the first approach in those severely affected patients. But then when we had at least 2 chelators, the combination of 2 drugs was introduced, and the most important for intensified case treatment is simultaneous treatment. And the background behind this is that those 2 drugs can exert not only an additive effect of the 2 drugs, but also a synergistic, based on this so-called shuttle hypothesis, so that a small chelator can go within the cell like a myocyte, they chelate iron, bring it out in the blood, and then a larger chelator who is not able to enter the cell itself can take up the iron from the smaller one and then excrete it via the kidney or the intestine. And so the first studies were done with the combination of deferoprone and deferoxamine, and showed very nicely an improvement of cardiac function related to lowering cardiac iron, but also improvement of glucose tolerance in patients affected by impaired glucose tolerance in the study presented there. Next slide, please. So meanwhile, I think the most broadly used combination treatment is that of deferoxamine and deferoprone. And so there was one study 10 years ago of comparing this new combination with the old one of deferoprone and deferoxamine, and it showed a comparable efficacy with regard to ferritin and liver iron, but even a slightly better efficacy of the new combination for the cardiac iron. So, and of course, it's for most patients more comfortable to take 2 oral drugs. And with regards to the side effects, it could be seen that there were not huge differences in both of these groups, and all were manageable. Next slide, please. And the last combination, which is probable, is the one of deferoxamine and deferoxamine, with maybe less potential for this shuttle hypothesis, but nevertheless, apart from the additive effects of the 2 drugs, which can be used, of course, for very severely affected patients, severely affected by high total body iron load and liver iron. Also, in this combination, in some patients, a synergistic effect can be seen. Next slide, please. Examinations experience in cell cultures using the different combinations of chelators did actually show that the combination of deferoxamine and deferoprone exerts the highest proportional synergistic effect. So this corresponds very good to the clinical results I presented you first. So this is really assuring that we have a good tool with this combination. Next slide, please. So now we go at the end. It was a short trip into history to show you what was done and where we are. So actually, it's more than 60 years ago, but not too much more than 60 years ago, that the first time a chelator was used, deferoxamine. But it took, next please, until 1977. That was actually introduced as a regular treatment and as a daily treatment in patients with thalassemia. And so you have to consider this if you are looking on life expectancy data and things like this, because only patients who were born after the early 70s could really benefit from regular chelation, and only in those countries who started at this time. Next, please. It took then several years longer until the first oral drug was developed, but even longer until it was introduced into practice in 2000 with deferoprone as the first oral chelator. And the next, please. And then a few years later, the second one, the Firazerox, was introduced with a shorter development time. But don't forget, next please, that at the same time, also about 2000, these new methods for RNA overload monitoring were introduced, like monitoring cardiac MRI by T2 star times, and also the broad availability of measuring liver RNA by the MRI. Next slide, please. All this together led to a dramatic decrease, particularly of cardiac disorders related to iron overload and to death within in the last 25 years, as you can see in the left panel. And it led to a really improved overall survival in the latest birth cohorts, as you can see from a large Italian cohort study on the right side. And as I said, so I think those who were born after 1975 were the first actually who could start at the age of 2 or 3 years at those times with chelation. But this is, I think, impressive. There's place to be better, and adequate diagnostic and treatment of iron overload are worthwhile. I hope I could show this. Next, please. And with this, I thank you very much for attention. I apologize once again for the technical troubles I was focused with, and I'm looking forward to questions. And I also thank for Helios for, yes, inviting me to this webinar. Next slide. Thank you.
Thank you very much. Do we have any questions? Petrus?
Can you hear me?
Yes.
So thank you very much for this presentation. So I'm not a clinician, but I have a question that maybe it's quite basic. But in terms of the different chelators that are available for thalassemia, for transfusion-dependent thalassemia patients, it has been shown, or there is evidence in the literature, that the oral chelators are better in terms of survival, depending compared to the previous ones. So is this because of better adherence of the patients, or is it that these drugs are just better than the previous chelators that we had in the market in the past?
So I actually think that, so we only have these 3 chelators. So I think the most important thing is compliance, and we had a lot of problems, and I'm old enough to have had this experience when we treated patients with deviroxamine only, how difficult this was. And it was not optimal, since we used a drug with a very short half-life, and to allow them a rather, at least a bit comfortable life, we gave it 5 days a week instead of 7 days a week, and it was present only overnight. So I think that's not optimal for chelation. And for this reason, I think the newest drug, which is meanwhile also 20 years old, the Firazerox, with this long half-life application only once a day, gives you a more continuous level, and even this makes a difference, even in those who are compliant. And then, as I said earlier, we had a different aim of chelation as long as we took only deviroxamine with this apparently optimal therapeutic range, which in fact was related to a number of complications, even with patients who was within this range, because it's not as physiologic as one thought it would be. I think these are at least already 2 factors.
Thank you.
Do we have any more questions? Looks like we don't have any more questions. Holger, do you want to say a couple of words? I don't want to put you in the spotlight, but about the TCD training we are organizing in September?
I think we first talk about it. So I would really appreciate that if there would be many who would like to come to Ulm. The exact date you know it better than me. I would have to look in the calendar.
19th of September.
And yeah, so it's not for hundreds of people, but for, of course, a limited number of patients. We are performing this one-day training course for transcranial Doppler ultrasound in patients with sickle cell disease with very experienced trainers who performed this type of training course already, I think, 4 or 5 times. 5, I think, for the last few years, and we have. So they are always filled. So I'm very positive this the next one. So which will then be the first with colleagues coming from abroad will be filled as well very soon. And I'm really looking forward to meet as many of you who will come here in Ulm.
Thank you very much. Thank you for this really nice presentation. For me, that I'm not clinician, it was easy to follow. It was really nice presentation. Anna, do you want to say something before we close as well?
Well, I would like to thank you, Holger, for the excellent presentation and all the high attendance numbers that we have today, all the attendees as well. And just to motivate you to join us on the 17th of June and the 19th of June, that are the 2 other webinars on this series that are on vascular access modalities for red blood cell exchange. And also the second one is alloimmunization and extensive red blood cell typing. So everyone is welcome. We will send a reminder by email, of course, as always. And thank you very much to you all.
Thank you, everyone. Thank you, Holger. Bye-bye, everyone.
Bye. See you.
Thank you. Bye.
Bye.